to be keeping everybody on mute so that we can maximize the audio that's available for Janice. But if you do have some questions, feel free to put them into the chat box. They will come up and we'll try and address those as we go along. Okay, so here's a little bit of information about Janice. So Janice Taylor has been a practicing physiotherapist for the past 18 years. She's operated her own pelvic health practice out of Port Elgin for the last 7.5 years. Janice treats a variety of conditions, including prolapse, incontinence, pelvic pain, prenatal and postnatal conditions, interstitial cystitis, post-hysterectomy, post-prostatectomy, and many more. She's passionate about educating and empowering her patients through knowledge and exercise. Her philosophy is that there's always something that can be done, and incontinence, although common, is not normal. So Janice, I will take my camera off and it's over to you.
Thanks so much, Leah. Okay, so I wanted to start by telling my story about how I got into pelvic health, because when I was in physio school, pelvic health was nothing more than just learning about Kegels, and that was it. There was we weren't taught how to do pelvic exams, and it was something that I never ever thought I'd be getting involved with. So my story is that 13 and a half, well, almost 14 years ago now, I had my first child, a boy, David, who's there on the left, and I had him quickly. Everything was seemingly fine. He was colicky. It was motherhood was tough, but I felt fine pelvic health wise. I went back to running and all the activities I normally did. And then 4 years later, I got pregnant with my daughter, who is in blue on the right-hand side. And halfway through that pregnancy, I didn't know what was wrong. I could feel like I had this falling out feeling, like the tampon was falling out, and it was really uncomfortable. And I ended up having a bladder prolapse, which made that pregnancy horrifically uncomfortable. And I went to a few specialists, and they basically said nothing could be done until after I had the baby. And then as a physiotherapist, I was like, why have I never heard of this? Why don't they tell women this? So I did all my research. And I realized that, there weren't that many great options. Like surgery was an option, but it wasn't that great. And so I ended up realizing that pelvic health physiotherapy was my best option. So after I had my daughter, I went to a pelvic health physiotherapist in Barrie, which, as you can imagine, with a 4-year-old son and a newborn baby, that wasn't very convenient. So I realized I could not be the only one in Grey and Bruce County with problems. So I started taking courses, and my goal was to help everyone else who had pelvic health issues, because it's actually quite common, prolapse, and I had no idea. And I was in the healthcare profession that actually helped people with it, but no one told me about it. So I was quite alarmed. So my goal was always to educate people on pelvic health issues, and that there's something that can always be done. It just takes time. So in 2011, when my daughter was 2, my son was 6, I started taking the formal training for pelvic health. So what is pelvic health physiotherapy, and what do pelvic health physiotherapists do? We are specially trained physiotherapists, so a regular physiotherapist cannot treat pelvic health issues to the extent that a pelvic health physiotherapist can. We treat urinary urgency and frequency. We treat incontinence, constipation. We treat what's called vulvodynia, which is a painful condition of the vulva. It's sort of a catch-all term, but anything that's painful involving the vagina or vulvar area. We treat painful intercourse. We treat interstitial cystitis or overactive bladder, and sometimes that can be known as painful bladder syndrome. We treat chronic prostatitis and prostatitis. That would be in men. Pelvic floor dysfunction, if you have it, when you're pregnant, and also postpartum. And then we also treat women pre and post gynecological surgery. My philosophy on gynecological surgery, if it's due to a prolapse or something, is to do the conservative route first and then if necessary, surgery, but always try to strengthen the muscles before a surgery. So what do we do that's really different than what a physio would do? I, in my practice, like to spend an hour and a half with a patient for an initial assessment, because I believe with everything, the details are in the history. The more detailed the history and the more you listen to the patient's story, the more you're going to be able to problem solve and figure out what's wrong. So I always take a detailed patient history. I do a really clear explanation of my assessment, because I do an internal exam, and I want them to understand why I'm doing it, what I'm touching, because it's very different from a pap smear. I do a thorough exam, so I will look at a patient's posture. I will see how they're breathing, because that has a huge role in how it's what's affecting their pelvic floor muscles. I look at their hip strength. I'll look at the external connective tissue. So that would be something like scars, if you had a C-section scar or an appendectomy scar. And then we do an internal exam. So the internal exam is all muscular palpation, looking at whether you can activate your pelvic floor, doing Kegels, that sort of thing. So I do an external exam, look at the vulva, look at the skin of the vulva, and just really do a thorough, look for any conditions, because there are many conditions that can cause itching or sort of dryness of the vulva. And then I do an internal exam looking at muscle tone and strength. But a lot of people don't know what the pelvic floor is. It's just a term we use. But I want to let you guys know what the pelvic floor is, because the more you connect with the pelvic floor, the more you're going to have an awareness of these muscles and what they're doing in your body. So the pelvic floor muscles are muscles that go from the pubic bone to your tailbone, and they wind around each of our pelvic organs. So in the female, they wind around the bladder, the urethra, the vagina, and the rectum, and they'll attach on the tailbone. And the male, there's obviously no vagina, but they wind around the urethra and the rectum. So they have a huge role in all of our daily activities. So they provide sphincter support, which prevents urinary and fecal leakage. They help support our bladder, our bowel, and our uterus. And in the male, they help support the bladder and the bowel. They help stabilize, because in females especially, we have ligaments in our uterus that attach to the sacrum. So they help stabilize our back and pelvic girdle. And one of the interesting things is if women have a hysterectomy, they often, well, not often, but sometimes they'll complain about SI joint pain. And that's because the ligaments are taken out. So there's a little bit less support for the SI joint and the back. So easily fixed with some core exercises, but that's just a common complaint after hysterectomy. Sexual function. So if we have normal tone in our pelvic floor muscles, that'll help with sexual satisfaction. If our tone is low or kind of weak, then we can have sort of lack of sensation. And if muscles are too tight, it can cause pain. So those are common issues I would deal with. And then the other thing that we might not think about too much is that our pelvic floor acts like a sump pump. All of the venous and the lymphatic return from the limbs, our lower limbs, all that needs to come through the pelvic floor to get back up to the heart where it can be pumped out again. So if we have a pelvic floor that's too low tone or loose or too tight, we won't have that sort of sump pump action. So the thing is, we demand a lot of our pelvic floor, and a lot of us have no idea what our pelvic floor is doing, and or poor awareness of those muscles. So my job as a pelvic health physiotherapist is to figure out what a person's pelvic floor is doing. Is it too tight? Is it too weak? Is the tone normal? Is it not? Is it causing what they're complaining of when they come to see me? So a normal pelvic floor is on the left. There you can see it's supporting the bladder, the uterus, and the rectum quite well. And it sort of acts like a trampoline. And in the other pelvic floor, you can see it's weakened. It's sort of hanging like a hammock, and the organs are sort of angled, falling back a bit. And so it's providing less support for those organs. So if someone has sort of like a pelvic floor that is on your right, so low tone, elongated, weakened pelvic floor, these are some symptoms that person might have. They might have urinary or fecal incontinence, or the other type of incontinence that we call, that is common with low tone pelvic floor, is flatulence incontinence, where you sort of pass gas without even really any warning. You'll bend over and whoops. So I think we all know grandmas that have had that happen, and that's usually from low tone. And then we can also get prolapse of the pelvic organs. So a lot of us have heard about people going for bladder repairs or a prolapse surgery. And that can be, you can have prolapse of the bladder, the uterus, and the rectum. And I will talk about those a little bit more later in more detail. But if someone has really low tone, they need to work on the strength of the pelvic floor with a structured program. We don't want to just do a couple Kegels a day. And we also don't want to overwork the pelvic floor with like a crazy amount of Kegels either, because then you don't have a pelvic floor working for when you're lifting mulch in your garden, or when you're lifting heavy groceries or moving furniture. So we want a structured program. I usually say for women, 40 Kegels a day, and then I teach them what's called the knack. So more important than just doing Kegels is to learn how to coordinate the pelvic floor when there is a downward pressure, a lift, a push, a pull, a cough. You want to engage your pelvic floor, and I call that the knack. Or the term I use in my charts is functional Kegels. You want to contract your pelvic floor every time you lift, because often when we go to lift, if we're lifting up a bag of mulch, we tend to hold our breath. We kind of go, and that creates downward pressure on our pelvic floor. So what we should be doing is engaging our pelvic floor, Kegeling, lifting the object, and exhaling as we lift the object. So it's Kegel, carry the object, and then you can put it down. Now, I did a talk at Bruce Power, the pensioners, last fall, and it was interesting. Most of my audience was men, and so they were all saying, "What is a Kegel?" So I'm assuming that you know what a Kegel is, but I realize that that's not really, I should never assume anything. So when I'm trying to get my patients to Kegel, about 10 or 20% of women have no idea how to engage their pelvic floor. So the cues I use to get them to contract, so you can try to do this with your own pelvic floor, would be to hold in gas as if you're at a party and you don't want to let the gas go. That would be the back part of the pelvic floor. If I'm trying to get them to engage the front part of the pelvic floor, I'll say, pretend you're picking up a blueberry with your vagina, which I know is weird and would never happen, but it gives them the visual to engage those muscles. And the other thing that works is maybe trying to suck up a milkshake through a straw with your vagina. Again, that sort of same analogy. For a male, I will tell them to imagine pulling their penis away from their body and then using their pelvic floor muscles to try to pull it back towards their pubic bone. So it's getting creative, because these muscles are inside us, but yet they are totally voluntary muscles, so we have control over them. Our brain just needs to realize that they're actually there. So using those analogies will help. There are certain cases where you shouldn't Kegel, though, and I will get into that next. So if someone has a pelvic floor that is too tight, those are people that should not be Kegeling. Those are people that I need to down train or relax their pelvic floor muscles. And fun fact, which we should all be aware of, is that jaw clenchers, if you're a jaw clencher, those are commonly my patients with tight pelvic floor. So if I am assessing a pelvic floor and I find a lot of tone, it's really tight, the muscles are rigid, I'll say, "Hey, do you clench your jaw a lot?" And often they'll say, "Yeah, I do." And so then I'll get them to connect with their jaw, or relax their jaw, and that helps their pelvic floor to relax as well. So tight pelvic floor, these are common symptoms. So the muscles have too much tension. It's like a sort of a fist that you can't let go of. They can't relax. So they should not Kegel. They need to relax. This can cause urinary frequency and urgency. Sometimes, especially in males, you can get incomplete emptying in the bladder. So it feels like they're emptying and then they're not, because they're sort of stopping the flow too soon. And then that can actually lead to infection. And and that happens in females as well, the incomplete emptying. Hesitancy tends to be a bit more common in males. It can happen in females, and that just means that you go to the toilet and you try to pee and then nothing's coming out. It takes a while for the flow to get started. Sometimes if you have a tight pelvic floor, you can have constipation because you're sort of fighting against the urge you need to relax your pelvic floor to let the stool out. So it's hard to let go. 70% of people with low back pain, actually it might even be 80% of people with low back pain that is not treated with conventional treatment, say traditional physio or chiropractic, that is referred pain from a tight pelvic floor. So if you have unrelenting back pain that nothing's working for, get assessed by a pelvic health physiotherapist. And then also pain during or after intercourse. And that can happen in males and females. A female with a too tight pelvic floor is definitely going to have pain with intercourse. So the other thing I treat is incontinence. And incontinence is common, but it's not normal. And the stats are 1 in 4 women are incontinent and 1 in 9 men. And usually in that statistic for men, it's as a result of a prostatectomy. It is not a normal part of aging or childbirth, although a lot of us, even a lot of health professionals will say that. It is actually common in younger women. 20 to 30% of young adult women report incontinence. And I've had a lot of patients that told me even as teenagers, they would pad up for track and field events. So it's really important to let them know that this can be treated. It's just not something they have to live with. The thing is, with women, if 20 to 30% of women have incontinence as young adults, that figure gets larger with age. It can cause depression. It can cause social isolation. A lot of my older clients won't leave if they're going to soil themselves. They tend to stay at home, which can lead to depression, and then also immobility. Limited activity, people that don't want to be active because they're afraid they're going to leak. A lot of them are afraid of the smell. They don't want to make anyone grossed out. And then also institutionalization, because if someone can't look after their own bladder and bowel functions, then really some of them have to go into residential homes. So you really want to address this problem before you are too old to deal with it, basically. And there is always something you can do about it. And no matter what the age, I've had 95-year-old patients, there's always something you can do. So types of incontinence. There's different types of incontinence, and I think it's really important. I always piece this out in my history. So if someone's got stress urinary incontinence, I'll say, so do you leak urine when you cough, sneeze, lift, jump? That's stress incontinence. It's more pressure related. And for a lot of my patients, it's not okay, but it's not as bothersome as something like urge incontinence. So urge incontinence is like a sudden loss of bladder control after a strong urge, and it can come on out of nowhere. And often it can be related to stress or tight pelvic floor. Or sometimes people are fine until they get out of their car, they put their key in the door, and they can't even make it to the toilet. So I always say their bladder is ahead of their body. You can have a mixed incontinence as well. So you can have stress incontinence where you cough and sneeze and leak, and also urge incontinence. In males, you can see overflow incontinence, and that could be because of enlarged prostate, which is sort of pinching off the urethra, so they cannot go to the bathroom fully, so they're constantly dripping urine. It's kind of like a tap that keeps dripping. And then you can have functional incontinence, and that can be related to like a cognitive impairment or mental impairment. It could be, say, you broke your leg and can't get to the toilet. And it can also happen to the elderly where they just cannot make it to the toilet in time because they're just slower getting there. So many different types of incontinence, and the type of incontinence is important to know, because you can't just say I'm leaking urine and expect someone to get better. You need to know what type of incontinence it is, so then you can target your assessment and treatment. So pelvic organ prolapse is really common. I would say about 50% of women have this condition. Some of it's just a mild prolapse, so it's not affecting people's lives. And it's very subjective. I just had a patient come in who was panicked about a bulge that she just noticed because she was going to Florida. She thought her bladder was going to fall out and it was going to be a medical emergency. So having had a prolapse myself and having lived with a mild prolapse for 10 years, but knowing how awful it felt when I was pregnant, I always try to downplay it because prolapse is just like a bad hair day. Yes, your organs have moved, but if they still work, we can deal with it. It's not an emergency, and you can do so much to strengthen your pelvic floor and not feel the prolapse. So the definition of prolapse is an annoying protrusion or bulge at or near the vaginal opening, which is worsened with standing and relieved by lying down or sitting down. It could be the bladder. It could be the back part of the vaginal wall, which would be a rectocele or like the bowel, or it could be the uterus. Often all three kind of fall in a little bit. It just depends on where the fascial or the connective tissue damage is. It's really a positional problem. The organs still work. They're just out of place. Hence my analogy of like a bad hair day for your pelvic organs. And we need to treat the problem functionally with postural correction. So posture and treating the pressures, managing constipation, because constipation is sort of the enemy when it comes to prolapse. And then work on pelvic floor, core, and hip exercises. One of my colleagues is in Stratford, and she had a 23-year-old woman with prolapse, significant prolapse. And this 23-year-old had never been pregnant, had never had kids, but just a lifetime of constipation and straining on the toilet. So avoiding constipation is really important for preventing worsening of prolapse. So symptoms of prolapse. If you think you might have prolapse, what you would experience is heaviness in the vagina, or rectum, feeling of your insides falling out or a tampon falling out feeling like you need to sort of support your perineum when you're having a bowel movement. People will sort of brace there, or they'll take a piece of toilet paper and support that area. Some people grab a mirror, or they'll feel it in the shower, a bulge or tissue at the entrance to the vagina. And if it's pretty significant, if you have a really large prolapse, you might have difficulty fully emptying your bladder. That would be a large prolapse though. So these are just pictures of prolapse so you can get an idea of what they are. And truly there's nothing wrong with the organ. Yes, the organ is shifting, but it's the wall of the vagina that has weakened and stretched, and the organ behind it is heavier. So it's pushing through into the vaginal space. People can still have intercourse with prolapse. They can still do everything else. It's just that the organs has sort of fallen in. But if you put something in the vagina, it will push the organ back to where it was supposed to go. So that's a rectocele. A cystocele is when the front wall of the vagina is weakened and the bladder falls back a bit. And you can see a cystocele and rectocele in this shot. The cystocele is at the top, the rectocele is at the bottom. And then what I always recommend is conservative options for prolapse. So working on your posture. If you're all slumped over, like many of us are, because we're all at computers and on our phones and sitting, slumping over means that there's more pressure downwards on our pelvic floor. So working into more extension, having good posture really does help prevent downward pressure on the pelvic floor. Core strengthening exercises and pelvic floor work. So, there is grade 1 or level 1 evidence that Kegels help with prolapse. So that means that it is like evidence-based that Kegels help to reduce prolapse. And sometimes it can improve a prolapse by a grade or 2, which is significant for the person experiencing it. If someone has a really extreme prolapse and they don't want surgery yet, or they're not a candidate for surgery, you can have an external support such as a V2 supporter. That's a support that goes over your underwear, and it's like a crotch support that will support the prolapse from the outside. It's like kind of like holding your hand down there, but it's, it's doing the job instead of you having to do that. Or reinforced triathlon shorts, which will provide more support down there as well. Use of a pessary, which is a silicone ring that goes in to support the bladder or the rectum or the uterus. And that's usually fitted by a gynecologist. What is new is that physios are now fitting pessaries. I do not do that, and I probably will never fit pessaries, simply because it's just a lot of work to disinfect and get an autoclave. So I will never fit pessaries, but I know some that do. Use of a lubricant to prevent dryness and rubbing. So I always recommend people, if they're in menopause, to use a lubricant. If someone is nursing and they're postpartum with a prolapse, I'll tell them to keep that area, an internal lubricant to the vagina to prevent dryness and rubbing, and it will make them feel the prolapse a lot less. Most prolapses can be treated conservatively with exercise, lifestyle modifications, and pessaries. Surgery is always your last resort. Surgery, I've seen great surgeries. I've seen surgeries that have gone bad. And you should always have your pelvic floor tested for Kegel strength before you have surgery. If you cannot do a Kegel, you're hoping that surgery is going to support your organs afterwards. And to me, that is not enough. We do physiotherapy for knees and hips before we get them replaced. We should be ensuring someone who's going for a prolapse surgery has decent strength in their pelvic floor so they can engage those muscles to support the surgery post-op. That means the surgery will last longer. So safe exercises. If you do have prolapse, or if you've had a hysterectomy, or you have stress incontinence related to low tone pelvic floor, and excuse the yawning, I'm jet lagged from getting back from Spain on the weekend. What you want to do is avoid exercises that put downward pressure on the pelvic floor. So sit-ups and crunches are famously not the best exercises. What I would encourage you to do is pay attention to where you feel pressure. I was just at a course about a year ago. It's called The Female Athlete, and it was all about CrossFit. And I have a mild prolapse, and I was a bit nervous. It was a very practical course, but it really changed the way I thought about exercises. So I actually don't say any exercises are off limits, although I do caution people with sit-ups and crunches if they have prolapse. What I tell people to do is, does it feel right? Do you feel any pressure? Like, really pay attention to your body, and are you feeling like your prolapse is worsening? Then don't do that. Modify it, change it, see if you can do something else that feels better. So if you say it feels okay, then that's not good enough. It should feel like normal. The other thing you want to do is work on your deep core muscles. So your transverse abdominis, which is one of your deep muscles that is like your corset muscle that goes all around your belly horizontally and it attaches to your spine. You don't really want to work on your rectus abdominis, which is your six-pack muscle. You want to work more in the deep core to help stabilize your organs. You want to do safe squats with the ball against the wall. Clam exercises, okay. I prefer weight-bearing exercises because you're actually doing something more functional. Anything that's good for your buttock or gluteal muscles is good for your pelvic floor. You want to avoid running and other high-impact exercises. I say that, but then again, there are certain running positions. I've trained some of my patients, if they're diehard runners and they have prolapse, if I can get them on an angle where they're sort of on a forward lean and their feet are behind or directly under them, not out in front of them, then that is easier on their pelvic floor and they can run better with the prolapse that way. Because sometimes patients don't take no for an answer, so you've got to work with them. Biking, walking, and swimming are all really good exercise if you want to get your cardio activity up and you have a prolapse. And there is a book, Inside Out, by Michelle Kenway. She is an Australian, and she's written a book on safe exercises for prolapse, people who've had a hysterectomy, anyone sort of with a weak pelvic floor. So that's a good reference too. But work with a pelvic floor therapist if you have a prolapse and you want to do some more intense exercises like CrossFit, running, high impact stuff, because you don't want to do more damage, but there are ways around it. You just got to have someone watch how you're breathing and your body mechanics. So the types of prolapse, just to summarize, you can have a cystocele, which is prolapse of the bladder. You can have a urethrocoele, which is prolapse of the urethra. You can have a rectocele, which is prolapse of the back vaginal wall. You can have a uterine prolapse, which many people come to me and they say they have a uterine prolapse, and I look at them and hardly anyone does. Mostly it's a cystocele or a rectocele that they have. And then if someone has had a hysterectomy, they can have a vaginal vault prolapse, which just means the top of the vagina can fall down. So, and I had a patient today again say she was panicked because she had a bladder prolapse, and then all of a sudden she had a rectocele. She had both and she couldn't believe it. And I said, I just made it normal. I said, you're really, the vagina is a potential space, it's usually closed. So if your bladder falls, often the back wall of the vagina, which would be the rectum would be behind it, will come down and meet it. So it's really rare to just have one wall fall. They usually fall together, but one organ is usually leading the pack. So when they do a bladder repair, it's often common that they have to do a repair of the back wall if you're having surgery, which should be always your last resort. And I think it's important to know what pessaries look like. So these are pessaries. Some of them, if you can remember the days of diaphragm for birth control, will maybe recognize some of the rings on the left. They look like diaphragms. So really, they will help support the prolapse. It's like a tampon. If you have a pessary in, you should not feel the heaviness of your vagina. You should not feel anything. And some athletes will wear these for like sports that are high impact if they feel the pressure of their prolapse. I tell my patients, if they're going to get fitted, be persistent. So the first time they might not like the pessary, it could be the wrong size, it could be the wrong type. So to go back again and again. I was at a course last April 2017, and when you're at a course, physios get into groups and we all practice on each other. And it's funny because all 3 or 4 of us in the group had prolapse, and we were all like 40 and under. So, and there was a one that was, 2 or 3 of them were using pessaries and with good results. So that's what I'm saying. Conservative therapy is always best. And then this is just an example of how pessary works. This is just a silicone pessary supporting a bladder and a uterus. And it goes in up high, and you should just feel like normal. You can forget about your vagina for the day if it's working. So constipation, the definition of constipation is straining to have a bowel movement or the production of a stool that is dry and cracked, like a pellet, like a rabbit pellet. So I tell my patients, you are constipated if you're straining or if you have a hard stool. You just need one of those criteria to fit the bill for constipation. Chronic constipation, though, can cause damage to the pelvic floor muscles. It can overstretch them. It can cause damage to the ligaments, the fascia, and the pudendal nerve, which goes through the pelvic floor. The bowel can push on the urethra and the bladder, causing urgency or urinary retention. Because the bowel and the bladder are so close together, if the bowel is really swollen with a large stool, it can push on the bladder and cause urgency. So someone's going to say, I have to go to the bathroom every 30 minutes. So when someone comes in with urgency, I always say, ask them about their bowel habits, because if they're constipated, if you cure the constipation, often the urgency goes away on its own. So how do we prevent constipation? We want to make sure we're taking in enough fluid, which we all know. We want to make sure that we take 1/2 ounce per pound body weight of water, or water-like fluids like herbal teas a day. We want to make sure our fiber intake is 30 to 40 grams per day. We want to exercise or move our bodies, even just going for a walk for 30 minutes a day. There is a massage of the intestines going from right to left, sort of up and across and down. And that helps just get food moving in the right way. That can help with sluggish intestines. Bending your knee to your chest, like we would with a baby, can help to stimulate bowels. And then also go as soon as you feel the urge. People are afraid to go in public bathrooms or at someone's house. And what I say is go when you feel the urge. If you don't go when you feel the urge, the stool that's sitting at the gate ready to go goes back up into the colon, where the colon's job is to suck the moisture out of the stool, and then it comes down drier and harder, and then it's harder to evacuate our bowels. So go when you feel the urge, because you only get that warning once or twice. And then that stool goes, oh, well, I'm going back up into the colon then. And the other thing is, and I apologize for this blurry slide, what we want to do is we want to sit on the toilet in a squat, like mimic a squat position. So you can see the difference between the anal rectal angle and sitting versus squatting. Sitting is, you can see that the stool has to pass through a more acute angle. And if you're squatting, it's more of a straight shoot down. So just mechanically, we want to get our knees above our hips. So you want to use a footstool that keeps the knees higher than the hips. We want to mimic a squat. We don't have to be like people in other countries that actually squat. We also don't want to hold our breath or bear down. We don't want to go, we actually want to breathe while we're having a bowel movement. So, and it also helps if we reach our left hand over our right shoulder and twist and look over our, oops, wrong way. Wait, right shoulder. And that kind of brings the bowel out, because the bowel ends on the left side. We don't want to strain. Instead of straining, you want to breathe out through pursed lips. You want to go, and then you want to, sometimes if someone has low abdominal tone, leaning forwards onto a book will help to increase the abdominal pressure without them straining and stretching the ligaments in the pelvis. Relaxing someone's jaw is really important. So if you're a jaw clencher and you have trouble evacuating, relax your jaw. Don't stay on the toilet for more than 5 minutes. Don't strain for 20 minutes on the toilet. You can cause damage that way. Just try 5 minutes. Nothing's happening. Get off, walk around, and see if the urge comes again. The urge will often come about 20 minutes after your next meal. And then this is just a representation of constipation, strain versus the squatting, and you can see the difference. Toilets, I think, are one of the worst inventions. Toilets, well, let's put it this way. In countries where they don't have toilets, where they have to squat, they have an easier time birthing their children. They have hardly any hip arthritis and less incontinence. So we should all be squatting. Interstitial cystitis. This is just a general term for painful bladder syndrome. It's a complex pain syndrome that involves pain, frequency, and urgency. It has been traditionally viewed as a condition of the bladder with treatment focused exclusively on the bladder. However, in a Finnish study of 25 to 31 women who were diagnosed with interstitial cystitis reported their pain was reproduced with palpation of the pelvic floor muscles, not the bladder. Bladder, and then in extreme cases, they've actually removed people's bladder, and bladder removal does not reduce their pain. So what is happening is that they have these sensitive pelvic floor muscles related to a sensitive nervous system. So often these patients do well with pelvic floor therapy, where a pelvic floor trained therapist will go in and release the muscles, release the trigger points. It's almost like a massage to let those muscles go, and then the bladder symptoms of urgency, frequency, and pain improve significantly. Often interstitial cystitis coexists with other conditions such as irritable bowel syndrome, fibromyalgia, vulvodynia, and migraines. I see it in a lot of patients that are stressed out. I also see this condition in a lot of patients with food sensitivity. So often if they have interstitial cystitis, I will encourage them to go to a naturopath if that's a possibility for them, to get their food sensitivity testing, and that's done with blood work, because often gluten, dairy, there's usually a food trigger with it. Sometimes it's even like oxalates in spinach. So, and then I also want them on a probiotic. So I find this condition is really well treated with me doing some manual work, or another pelvic floor physiotherapist doing manual work, with the help of a naturopath, and then often with the help of a psychologist, because often there's a triggering event. It could be childbirth that just was traumatic. It could be a surgery. It could have been like a really nasty bladder infection, and I have a lot of those on my caseload. Psychological, emotional trauma. And that doesn't have to be a significant trauma to us, but it's significant to them. Like even a trauma could just be something that a lot of us would brush off, but they absorb it as a trauma. So it's best treated with several health professionals at the same time. That's when I see the best results. And then will the bladder heal? Well, of course it will. Often it's just related to tightness and stress. If someone has Hunner's ulcers in their bladder with interstitial cystitis, it takes longer to get better. But we have mucosal linings everywhere in our body, our mouth, our intestines, our nose, and those all heal when they're damaged. So given the right environment, physically and emotionally, the bladder can heal too. People can do really well. It's always a shame to me when someone has had interstitial cystitis for like 12, 15 years, because then they're in a pattern. So we've got to break the pattern and retrain everything. But if we catch them early, they'll heal faster and better. And then this is just an example of the multifactorial approach to interstitial cystitis. And the general term could also be chronic pelvic pain syndrome. And we really just want to work on retraining the brain, the nervous system, finding out if there's any sensitivities, and really eliminating the stressors. Because when we're stressed out, we have excess cortisol, we have excess inflammation, and that affects our nervous system and our sensitivity, and urgency, frequency, pain all goes up. So calming the nervous system is really important. So in general, how would I treat interstitial cystitis? We want to release pelvic floor trigger points, so some manual therapy. I want to look at connective tissue in the legs and abdomen. Sometimes scar tissue is involved. Sometimes really tight inner thigh muscles are contributing to it. Stop Kegels. So Kegels are actually contraindicated in interstitial cystitis. Kegels will make people worse if they have it. So stop Kegels. Do reverse Kegels, which means you want to try to relax your pelvic floor. You want to relax your jaw. Stretching, yoga. Yoga is really good for mind, body, helps reduce inflammation. Stress management, meditation, finding your trigger foods and avoiding them. Another trigger food that I've had in several patients is nightshades. So nightshades would be tomatoes and eggplants and red and green peppers, potatoes, white potatoes. So avoiding those. Keeping your urine dilute, lots of water helps. Avoiding constipation, that really tends to irritate people with interstitial cystitis. And having Epsom salts baths to help relieve the tight muscles, because Epsom salts have magnesium in them, and magnesium helps to relax tight muscles. Another thing I treat, which is very common, is painful intercourse, or the fancy name for that is dyspareunia. So dyspareunia is the medical term for pain during intercourse. Most of this time, pain can be attributed to myofascial trigger points, so like tightness in the muscles, tight tissues, connective tissue dysfunction or scar tissue, skin disorders of the vulva. So I would see lichen sclerosis or lichen planus. And I say those names not to have you worry about them, but if you have those conditions, know that pelvic health physios can treat you and help you. Episiotomy scars from birth or C-section scars can also cause pain with intercourse. Pudendal neuralgia, which is the pudendal nerve runs through the pelvis, and the muscles, if they get tight around it, it can irritate that nerve. And then also, like if your bladder is really sensitive or the uterus is sensitive, that can cause pain with intercourse. So always ask patients whether it's deep pain or superficial pain. Where is the pain when they're having intercourse? So what we want to do is treat the underlying cause of pain and help reduce anxiety, and that helps reduce the pain. There is a really vicious cycle, especially in a female, if they've had pain with intercourse, where they will tense up their pelvic floor because intercourse means pain, so they're anticipating pain. So what do? They tense up, and then that creates more tension and more pain, and then that creates more anxiety. So we really want to teach them to relax their pelvic floor. I often use dilators and get them to work on that sort of sensation so they're in control, so they're pain-free with a dilator, which just helps to stretch the opening, and then teach them that certain positions are better than others. But we really want to de-dramatize, work on deep breathing, and work on relaxing the pelvic floor muscles. And I see a lot of pregnant women, lots of pregnancies in Port Elgin lately, and the moms are keen and they want to protect their bodies. So this is just an example of a baby sitting on a mom's pelvic floor, and there's a lot of pressure on a pelvic floor during pregnancy. So the weight of the pregnancy stretches the pelvic floor. women who have a prolonged pushing stage are at risk of pelvic floor damage. So I like hearing patients that just push for 20 minutes or 10 minutes. If they push for 3 hours, I'm a little bit more worried about their pelvic floor. Positions most damaging to the pelvic floor are the ones most women give birth in, which is lying on your back, because you're essentially pushing uphill, and your sacrum would not, your pelvis, it does not open fully on your back. You're better on your side, on all fours. You're better squatting and high kneeling. You're better in any other position than your back when you're giving birth. And then interventions such as forceps, episiotomy, and vacuum all increase the risk of damage to the pelvic floor. So really, ideally, if I can get a woman when she's pregnant, I would love to, I always check for the effectiveness of her Kegel. I want to make sure she can Kegel properly, because it's a lot harder to learn that after they've had trauma to the pelvic floor. The Canadian Society of Gynecologists, along with the Canadian Physiotherapy Association, recommend initiation of pelvic floor exercises in the immediate postpartum period to reduce the risk of future urinary incontinence. And then approximately 45% of all pregnant women have SI joint pain or pelvic pain or pubic symphysis pain. And there is a huge connection between pelvic floor dysfunction, so tightness on one side of the pelvic floor, and sacroiliac pain or pubic symphysis pain. Constipation is also a major cause of pelvic floor damage in pregnancy. A lot of women, due to the hormones, will have pregnancy-induced constipation. I know I had that in my second pregnancy, and it was awful. And then in France and Germany, women are given 6 to 10 pelvic health physiotherapy visits funded by the government in the immediate postpartum stage. So they really have taken care of their women postpartum, no matter whether that baby comes out vaginally or by a C-section. They get pelvic health physiotherapy. And so should we. We need to start demanding more of our government. So women should not be doing, if they're postpartum, women should not be doing any high impact exercises like running, jumping, unless they have a grade 3 out of 5 pelvic floor strength. If their strength is less than that postpartum, they risk pelvic floor damage. So a lot of women don't like their bodies after they have pregnant. They want to start running or get back to the gym. And really, they should not. They should be assessed at 6 to 8 weeks postpartum by a pelvic floor physiotherapist and have their strength tested. 3 out of 5 means they can contract their pelvic floor against gravity. 0 out of 5 means they've got nothing. 1 is a flicker. 2 is a little bit of a contraction. 3 is just against gravity. So there's not even resistance there. I like women running when they have a 4 out of 5 or more. And then no woman should go to boot camp without first working on her core from the inside out. But that's the thing. A lot of women go to boot camp because they don't like their mummy tummy. They want to get their bodies back. And that's not ideal. You've got to be patient with your body. It took 9 months to get that way. So you want to work from the inside out to get it back. Pelvic floor physiotherapists also check for the separation of the abdominal muscles, like a diastasis. And there's a few really effective exercises that will help close that. We check for proper postural alignment and breath. And we want to get that diaphragm that's been tucked under the ribs back working again, and get the core coordinated again. And then we also treat men. About 20% to 30% of my caseload is men. Some of them have chronic prostatitis. That would be a younger population. And some of them have had their prostate removed. So chronic prostatitis is the same thing basically as interstitial cystitis in females. It's a bladder pain syndrome. Often it really doesn't involve the prostate at all. It's more tightness in the pelvic floor muscles. And I see it really, I've treated enough of it to know I think that there's a huge amount of stress involved, which creates muscle tension. So it's really working on the stress piece and then teaching them to connect with their pelvic floor so they can relax their pelvic floor muscles. But a lot of the men I treat are in pain. A lot of the urologists, well, some of them might use the U-point system, which looks at urgency, frequency, psychological factors like stress and anxiety, looking to see if the male that have this condition, whether they have ulcers in their bladder, and then they'll look to see if there is inflammation in the bladder or prostate, tender muscles, that sort of thing. I tend to focus on the tight muscles, and I'll treat the tight muscles and really educate my patients with regard to stress management. And then, of course, I treat many pelvic floors pre and post-op. So that could be a hysterectomy. It could be a male who's just had their prostate removed, so they're leaking urine. So it's always a good idea to have a consult. If you know you're going to have a pelvic surgery, go to a pelvic floor physio to ensure that you can coordinate your muscles before you've had the trauma of surgery. It's harder to connect with those muscles if there's swelling and damage. So surgery is best supported. Any surgery is best supported with strong, coordinated pelvic floor and core muscles. If you think of a hip and knee surgery, most patients have physio before hip and knee surgery, and then they have physiotherapy after. So traditionally, people go for bladder lifts or hysterectomies, and that's it. They just go back to their lives. But then a lot of them will reprolapse or have problems, or they might have scar tissue that's painful. So if they saw a proper therapist, they could deal with those issues, and the surgery would be more effective and last longer. So physiotherapists can assist in reducing painful scar tissue adhesions and get the muscles coordinated again. And then I think this is the final thing that I'm going to talk about with respect to conditions, but chronic pelvic pain, this is something we see. This could be anything. It could be interstitial cystitis. It could be vestibulodynia, which is pain at the vaginal opening. It could be lichen sclerosis, which is a skin condition of the vulva. It could be anything. But what we do is we treat and educate patients on persistent or chronic pain. Because after 3 to 6 months after you've had a condition, if pain persists, like the tissues have healed. So if pain persists, it's often the result of a sensitized nervous system. So really, I teach patients what pain is. I teach them how to manage their pain and other factors that can help reduce their pain, and how to get them moving again pain-free once we know that there is no tissue issue. So these are really, if you have persistent pain, these are well worth the watch. I give these to all my persistent pain patients. Understanding pain and what to do about it in less than 5 minutes. I get them to watch Arthur's Amazing Transformation and The Strange Powers of the Placebo Effect. Each of those videos is 5 minutes. And then I get them to watch those again and again. If they forget what pain is and the effect of the pain on the nervous system, I'll get them to watch it. Because pain's role after your tissues have healed, after 3 months, is not valuable anymore. Pain is there. When we hurt ourselves, pain is there to stop us from doing something. The pain is not there to tell us what tissue has been damaged, how bad it's damaged. That is not the role of pain. We can have pain without tissue damage, and we can have tissue damage without pain. So I really try to educate on pain, because a lot of people who have pain are afraid, and they're afraid that when they move a certain way, they're damaging tissues. And after the tissues have healed, after 3 weeks, if that pain is still there, they're not damaging tissues. That pain is not as effective, and we have to retrain the nervous system not to protect with pain anymore. So that's basically what I just said, pain education. We need to understand the need for shifting your thoughts and beliefs about persistent pain. In my case, it's often pelvic pain. I teach my patients to understand the neurophysiology of pain, because with increased stress often comes increased pain. If we can reduce our stress, we will reduce our pain. I help them to understand and address any sleep difficulties. Poor sleep contributes to persistent pain, and vice versa. I train my patients to think positively. I'll give them guided imagery, guided relaxation, and that will help calm their nervous system down. And I have a pain booklet I have my patients work through, because pain is exhausting and it's real. But when pain is not useful anymore, we want to train the nervous system to get rid of it. So these are some great resources for pelvic health. Pelvichealthsolutions.ca is a website that's was created by my mentor. It has a lot of great information. It's lots of pelvic health physiotherapists are on there. Some great books: Headache in the Pelvis, Healing Pelvic Pain, Inside Out, the IC Survival Guide, IC Network, chronicprostatitis.com. Those are all great resources. You can contact me anytime. Yeah. Why is pelvic? It's there twice. The pain, the whole truth, and nothing but the truth, inside out. And I think I have that twice there. That's kind of funny. What I will say is, just locally, if you're in the area locally, there is 3 pelvic health physiotherapists in Owen Sound. I am in Port Elgin, and there is one in Kincardine, and there are many in other cities. And if you're looking to find one, Pelvic Health Solutions, the website there has Find a Pelvic Health Physiotherapist. It's listed by city, so you can literally look up the city, or you can go out of province and find a pelvic health physiotherapist closest to you. And that is it. Anyone have any questions?
Yeah, if you have any questions, just put them into the chat box, and Janice will be happy to answer those as they come up. Janice, thanks a lot. I don't think I'll look at a blueberry the same way. That'll be my reminder in the morning, right? I know. I'm really close going right now. But this is such an important, I mean, it's a plethora of information. There's so much in here. And we'll definitely get this out to our consultants as well, so that they can use it to continue spreading the information. That there really are so many things that do not need to be approached surgically, and yet oftentimes that's the immediate go-to, right? When there can be some less invasive and definitely high impact benefit that people can get from engaging with a pelvic health physiotherapist.
Absolutely, yeah. And education is key. Once people understand their bodies, it's like the fear factor is gone, and it really just helps them to get a handle on the situation. And even in the case where surgery is necessary, having the physiotherapy first really helps them along. It helps the surgery be more successful, and then you can prepare them for the tricky post part, having a bowel movement post-op, all that kind of stuff. So, yeah.
Yeah, and even as you said, for those who, like for those women who are preparing for birth, that there are things they can do to make the birthing process easier, therefore make their, have a healthier outcome, healthier baby, and also speed their healing process after the fact as well. So
absolutely, yeah. I have a yoga instructor I work with, and we do our own 6-hour, 7-hour prenatal class to empower women to basically know the positions, know how to breathe, so they know what to do when the time comes, so they're not a deer in the headlights. So, yeah.
And there does seem to be a culture shift away from just accepting whatever the doctor tells you to taking more control over your own health. And as you said, that speaks directly to the more educated, the more aware we are, the more we go in with our own ideas and our own basic understanding, so that we can choose better what's in our own best interest. And women talk to each other.
They do.
And so I think if we can get the message out to 100 women, it'll probably get out to 1,000. So
exactly. Yeah.
There doesn't seem to be any questions coming up. So I will, if for those of you who were on our webinar tonight, please spread the word. We'll be getting the recording out to each of our corporate locations. Feel free to share, family, friends, everybody. And thanks again, Janice, who joined us from Port Elgin tonight, and pelvichealthsolutions.ca.
Yeah, you got it. Yeah.
Where you can find a pelvic health physiotherapist in your area. So.
Perfect. Thanks so much for having me. It was great fun.
Great. Thanks, Janice.
All right. Take care. Thanks.